The evaluation of anemia begins with a single foundational step, confirming that anemia actually exists. This is done by measuring the hemoglobin concentration on a complete blood count. Anemia is formally defined as a reduction in circulating red cell mass below what is needed to meet tissue oxygen demand. In clinical practice, we detect this as a hemoglobin below sex and age-adjusted reference ranges. Broadly, less than 13 grams per deciliter in adult men and less than 12 grams per deciliter in non-pregnant adult women, according to WHO criteria. It is crucial to understand that hemoglobin tells you that the patient is anemic, but it does not tell you why. To answer the why, we turn to the next index on the complete blood count, the mean corpuscular volume. The mean corpuscular volume, or MCV, measures the average volume of a single red blood cell in femtoliters. It partitions anemia into 3 morphological categories, each pointing to distinct disease mechanisms. A useful conceptual frame here is that MCV reflects the quality of erythropoiesis. When the bone marrow cannot make hemoglobin properly, it tends to push out small cells, which we call microcytic. When DNA synthesis is impaired and nuclear maturation lags behind cytoplasmic maturation, the cells emerge large, which we call macrocytic. And when the marrow is producing structurally normal cells, but either too few of them or losing them faster than it can replace them, the cells remain normal-sized, which we call normocytic. These 3 branches are microcytic with an MCV below 80 femtoliters, normocytic with an MCV between 80 and 100 femtoliters, and macrocytic with an MCV above 100 femtoliters. Each branch then has its own designated next test to pursue. In a microcytic picture, the dominant problem is impaired hemoglobin synthesis. Because hemoglobin is built from heme, which requires iron plus globin chains, anything that disrupts iron availability, heme synthesis, or globin production produces small red cells. The first test to order is serum ferritin, which is the storage form of iron and the single most useful surrogate for total body iron stores. A low ferritin is essentially diagnostic of iron deficiency anemia, the most common cause of microcytic anemia worldwide. Common causes include chronic blood loss from menstrual bleeding or occult gastrointestinal bleeding due to peptic ulcer disease or colorectal malignancy, inadequate dietary intake, malabsorption from celiac disease, post-gastrectomy states, or H. pylori infection, and increased physiological demand during pregnancy, infancy, or adolescent growth. Ferritin is highly specific for iron deficiency when it is low. A value below approximately 15 to 30 nanograms per milliliter essentially confirms the diagnosis. However, ferritin is also an acute phase reactant, so it can be falsely normal or even elevated in the setting of inflammation, masking concurrent iron deficiency.